very well, because of many reasons, we may have post-traumatic kyphosis. And I would just go through, give a brief introduction about these problems and etiology about it, and prevention, management, and of course, I will have key points. You can see here, I'm putting my first, thumb within this two spines process, because this two spines process already widened, as you can see that. This is a kind of the compression destruction injury, or AOT type B injury, kind of chance fracture or injury here. Mostly ligamentous. You can see that is a kyphosis. This lady is 46 years old, and she got a traffic accident, and she got many comorbidities because of this one. And then probably our colleagues during that time neglected her problem. But she actually admit to my clinic with a severe pain, but without any neurology. I'm gonna show the result of this case. Sometimes we neglect these kind of problems because of the multi-system injury. And this is a potential complication of spinal trauma, as already we all know. And sometimes it's a major, sometimes minor trauma because of the minor trauma, because of the low quality of the bone. And patient can be presented with deformity, both mostly sagittal, but sometimes coronal too, and sometimes because of pain, mostly, and sometimes progressive neurologic deficit. What is the problem with this important pathology? Sometimes we cannot evaluate patient properly, and sometimes we cannot follow the patient again properly. We may have some insufficient pre-op planning. I'm going to show some case examples about this one. Again, a poor surgical technique, especially not to protect the midline structures at below and at above, also creates some problem. Of course, non-union, another issue. How can we prevent this one? Of course, if you know the reason, we can prevent this one. We should actually classify patients. If we predict the instability, then we need to actually treat this kind of patients aggressively, especially unstable burst structures and type B injuries, as I show you. And careful pre-op planning, another important issue. Sometimes some patients have neglected problems, the multi-level injury, and then let's say we see the T12 L1 fracture, but she got, or the patient has the T8 fracture as well. So this is common for the high actually energy trauma patients. So we need to evaluate this kind of patients preoperatively in detail. And we need to have a meticulous surgical technique, avoid unnecessary laminectomy. If there is no neurological deficit, this is very well accepted, universal accepted rule. You don't need to do any kind of laminectomy, and we need to do biomechanically secure fixation for these patients. Of course, we have some kind of anatomical considerations, especially thoracic spine. It's very well tolerated. Patient may develop a hyperlordosis or hypokyphosis, and then balance the sagittal part. But in lumbar part, especially the lower lumbar part, this is very difficult because the patient doesn't have too many mobile segments at the bottom. So sometimes they cannot actually tolerate or compensate their problems. So lumbar deformities creates more and more problems. What are the surgical indications for this problem? Progressive deformity, focal instability, refractory pain, and of course neurological deterioration is the most important one. How can we evaluate the patient's deformity? Sometimes patients have flexible deformity, so we need to go for fulcrum extension. We can put a bolster at the back and ask the patient to laying down on this bolster in a supine position and take a lateral X-ray. If this the flexible on this position, then we don't need to do a kind of excessive osteotomies and other things so on. Just putting in this position pedicle screws. If unless are there any, if there is a anterior column support, of course, we need of anterior column support, we need to do that. In rigid deformities, we may need some kind of osteotomies, and these are SPOs, PSO, or sometimes some kind of PVCR. And this is published in 2008 in Spine Journal. Decision-making diagram or strategy for this kind of patients. You can see that we start with the normal sagittal balance or sagittal imbalance, and then we are doing smooth kyphosis or sharp angular kyphosis again, and thoracic lumbar or minor or major imbalance, and then we can actually decide SPOs and PSOs for these patients. This is 22 years old, young man, and he got back pain and deformity. Actually, he's waiter of our hospital's restaurant, and actually you can see that there is no too big deformity actually, but there's a sharp kyphosis, but he always complaining about the back pain. He's doing some kind of exercise and rehab, but still, and there's a fall from height 5 years ago. There's a history of trauma, and during that time, and in another hospital, they treat this patient with the anterior spinal fusion, and there's no neurology now. You can see that they did a surgery at this level, but probably they neglect this one. Maybe it's the wrong level surgery, I don't know. We don't have pre-op x-rays of this particular patient. He got a mild scoliosis as well at this level. And then during that time, like if I'm right, this 9 years ago, we did this surgery. During that time, it was really rigid. And first, we actually remove the anterior part of this construct, and then flip the patient. During that time, we did the anterior surgery and then anterior release together with removing the implants, and then did a posterior combined surgery. But now, actually, I always thought about the different things. Now, I think we didn't need to remove the anterior implants because it's a big surgery, creates many complications. We may do from the posterior probably in this time, but 9 years ago we did like that. This is the post-op outcome of this patient, the post-op 2-year follow-up. We have the X-rays, but still he's doing well actually, because doing the same job in our hospital. This is a 25 years old man, had traffic accident, and actually again in another hospital they did as usual bad surgery is done by the other hospital. So that's why the rule is valid in this patient as well. But the interesting construct. This is a kind of plate. I don't know why they put the screws is not good, and then they did a laminectomy here. And before the operation, he didn't have any neurologic deficit, and he did a laminectomy, our colleague, and then do this funny construct. Of course, everything is pulled out, and then it creates a kind of a rigid deformity at the thoracolumbar junction. What we have done is doing a pedicle subtraction, which is the Schwab type 3 osteotomy here, and then remove all of the construct. We actually missed one of them. Here is a washer over there under the skin, and do a knee construct for this particular patient. This is post-op year 1. Now coming back to our patient, pure ligamentous chance. This patient in flexibility X-ray, she did not correct, and then I thought I need to do a kind of osteotomy for this patient. But during the operation, probably he got a kind of facet dislocation, locked facet dislocation. During the operation, while removing the facets, she can easily actually reduce. And then I did just one level above, one level below, just one level actually fusion at this particular level in order to prevent to keep some mobile segments up and below. So this is the 9-month follow-up of this patient. Of course, we need to understand the mechanism of injury very well in order to prevent this problem. And we need to do a very good pre-planning. We should apply optimal and good surgical technique. And of course, we need to be prepared the different type of osteotomies for tackle this problem. Thank you very much.
Thank you. Any question or comment? Yes, please.
Are you using anterior supports, anterior spacers, like cages or bone grafts for the anterior and the middle column support in these cases, in addition to steel tension band?
Yeah, it depends actually. As I mentioned, if I think that the patient needs a kind of anterior column support, yes. But not all PVCR cases. I don't use all of the PVCR cases. I'm just look at the patient's actually stability during the operation. If I think that I resect too much and then I put a cage to the anterior, but I always put on my operating table is a kind of cages and other things so on. But this is not a routine procedure actually. I try to not to lengthen too much spinal in order to prevent the tearing of the spinal cord, and not to actually how do you say compress it. I mean the spinal cord in order to kinking of the in order to prevent the kinking of the dura.
Yes, thank you.
Any further question? No. Thank you very much, Dr. Şenköylü.
My pleasure.
I invite Onur Yaman for his lecture about